The next program we have fits perfectly with both the efforts that Barbara Burton has made in newborn screening and that you've heard about from Michael Gelb. And this is how newborn screening will transform the landscape for the MPS community. I say that I'm also mindful that there are patients who will not benefit from that and families who will not benefit from that. I want you to know that we also have you very prominently in mind. We work to try and develop therapies that lead to stabilization or improved management, as well as those that may be more definitive that are associated with newborn screening. So we're working for the entire community, even though we're focusing on these kinds of developments right now. The next speakers are an acknowledgement of how important newborn screening and early initiation of therapy is. They are all genetic counselors. Amy Gaviglio is a member of our scientific advisory board. She works with the CDC, the Association of Public Health Labs. She'll be providing an overview of newborn screening. Caitlin Coolin is a genetic counselor and works with something called Genome Connect, which is a program that allows families to upload their genotypes as well as a health survey to help inform future decisions for people who are diagnosed. And Jenny Goldstein will talk about an effort that allows us to more effectively categorize genetic alleles, et cetera, in the MPS disorders. So without further ado, I'm going to hand it over to Amy. The other speakers will come up individually, and then we'll come up as a panel and take questions at the end. Thank you. So please give Amy a big welcome. Thank you.
Perfect. So thank you so much, Matthew, and thank you to the MPS Society for the invitation today to speak to on a topic that's really near and dear to my heart. These are my disclosures. And for my 20-minute section today, this is really the journey that I want to take us on. And I want to start by setting the foundation of understanding the newborn screening system as it stands today, including where we are with screening for some of the MPSs. Then we'll move to thinking about how the newborn screening system really needs to evolve. And then we'll end with how those of us in the room can really help drive this modernization that is so desperately needed within the newborn screening sphere. So we'll start with that overview. And I fully appreciate that it is a risk to start a talk with a history lesson, especially at the end of the day. But bear with me, because I really want to start by setting the tone that newborn screening today exists because of advocacy, because of families, clinicians, and researchers like you. And I think it's important to start with this because I do often hear families who are nervous about advocating in newborn screening, who maybe don't feel like they belong at the table. But I want to remind you that that table exists only because of people like you, only because of advocacy. And so if anyone has a right to be at that table and to help shape the future of newborn screening, it is you. And we can go back to our first disease that we've started newborn screening for, which is phenylketonuria, or PKU. And really the whole existence of this disease, its treatment, and its screen is because of advocates. So we can go to 1934 in Norway. We have a mother who had children who had intellectual disability, and she relentlessly worked with her physician to understand why that was. And that led to the discovery of PKU as a disease. Then we go a decade or so later over to Britain. And here we have a mother who now knows she has a child with PKU and is not satisfied with the idea that there is nothing that can be done. And so this leads to the development of the phenylalanine-free formula, which is still a crux of our treatment for this disease today. And then from there, if we go across the pond over to the US and we look at clinicians, scientists, and advocates on that side, this is where we start to take the pieces together. Now we have a disease, we have a treatment, and we want to be able to pick this disease up more quickly. And so that's when we see Dr. Robert Guthrie, who's often known as the grandfather of newborn screening, inventing the assay that really sets the tone for newborn screening as we know it. So I have basically condensed, excuse me, a 60-year program into 4 key takeaways. These are really important for us as we think about the potential for advocacy in this space. So first and foremost, newborn screening programs are considered public health programs. And that means that they are administered at a state or jurisdictional level. However, successful newborn screening programs do require knowledge and coordination of multiple partners, and I'll get to that a little bit more in a second. In the United States, newborn screening programs are state-based. There is some federal oversight, which I'll talk about a little bit later, but by and large, the administration of newborn screening programs happens at the state level. And why that is important to understand is because each state will do things a little bit differently. They will screen potentially for different diseases. How they screen for diseases will be different. The follow-up available to families will be different. And as you think about advocacy, that's an important thing to understand. Newborn screening programs are also considered kind of opt-out or quasi-mandate programs. What that means is that the default is for newborn screening to occur. We're not getting explicit informed consent as we typically do when we think about genetic testing or other tests. In almost all states, parents can refuse newborn screening on behalf of their child. And then the final point I want to make is that newborn screening programs are designed to detect treatable conditions. And in order for diseases to be on a newborn screening panel, they need to meet a certain criteria, including that there is an effective pre-symptomatic treatment. So my first bullet on the last slide indicated that newborn screening programs require multiple partners. And I think when I say that, most people think, yeah, of course, Amy, it means we need a public health department, we need the clinical department, but we actually need so many more partners that span a number of places: the clinical system, the medical system, family support, resources, advocacy, research, technical support. And each of these partners play an important and critical role in both the success of newborn screening today and its future. And I want to really focus us today on these ideas of how we in kind of family support and advocacy can really bolster this system. So again, I also mentioned that newborn screening, that diseases need to meet certain criteria in order for them to be deemed appropriate for population level screening through the newborn screening process. We still rely heavily on these 10 key principles known as the Wilson and Youngner criteria that describe characteristics of diseases that make them appropriate. In the interest of time, I'm not going to go through all of them, but I do want to highlight a few. So the first is that there needs to be an accepted and effective treatment. I mentioned that already. We have to have centers available to diagnose and treat and manage these children. We, of course, need to have a suitable test or way to test these children, and Dr. Gelb presented that beautifully in terms of being able to say this child is at high risk for having one of our diseases versus this child is at low risk for having one of these diseases. And then we have to look at overarching system costs as well. And one of the last things I'll mention as we think about newborn screening is most of the time when I talk about newborn screening, this is kind of what we think about. We think about it as the test, the little heel stick that happens, the running of the assays, getting a negative screen result, a positive screen result, getting worked up by a clinical physician or specialist, and then being told, yes, it was a false positive result, or no, this child is actually affected. But everyone in this room knows that these diseases are lifelong. And when we think about newborn screening, we have to think about the entirety of the lifespan and making sure that we have the systems and infrastructure in place to support the families really throughout, beyond that initial diagnosis, through the points of management, transition to care, transition to adulthood, et cetera. So now that we have a little bit of a basis of kind of what the newborn screening system looks like and what makes a disease appropriate for newborn screening, how do you actually get a disease onto a newborn screening panel? And by and large, this is actually done at kind of starting at a federal level. And the group that oversees this is known as the Advisory Committee on Heritable Disorders in Newborns and Children, which for obvious reasons I'll be calling ACT-DNC from now on. But this is a federal advisory committee that is overseen by HRSA, the Health Resources Services Administration, and they advise the Secretary of the HHS, Health and Human Services, on which diseases make sense for newborn screening. There are a number of members. Currently, we have 8 members, 5 ex officio members who typically represent the federal government, CDC, HRSA, FDA, NIH, et cetera. And these members are all voting members. There are also a wide number of organizational representatives that sit and provide their insights as well. However, these individuals do not vote. So what does this process look like to try to get your disease on what we call the Federal Recommended Uniform Screening Panel? It's actually a really long and arduous process. And it's something that is an area where I think advocacy could be really well received in terms of trying to think about how we can change and modernize this process to meet the ever-growing needs of adding diseases. But basically, you have to submit a nomination package to HRSA that shows how your disease meets all of those criteria that I showed earlier. They will review that package. It will go through kind of a mini review to start. It will go through a vote, and if they vote yes, that sets a 9-month clock for a full evidence review. After that 9 months, that will be presented to the committee. The committee will vote on whether or not to add the disease, and that opens up another clock where it goes to the secretary for waiting. So you can see already, just after you've already garnered all of the evidence, we're talking about a nearly year-long process. And so this is definitely something that Dr. Gelb, Dr. Ellenwood, and I have been talking about in terms of potential needs for advocacy and expedition. However, there have been at least 2 diseases that have been successful in going through this process. Dr. Burton mentioned this beautifully earlier. So we have MPS 1, which was added in 2015. We do have 45 states that are screening, which account for about 85% of the birth population. MPS 2 is added in 2022. We have 13 states currently screening already, which is about 40% of the birth population. As Dr. Burton mentioned, once we add one kind of disease in a category, it does often become more easy to add more and more diseases. We do have one state that is screening for MPS 4A. Interestingly, it's the state of West Virginia. MPS 4A has not gone through that federal process, but was added through legislative mandate to their screening panel, largely owing to the advocacy of a clinician who is on the West Virginia Newborn Screening Advisory Committee panel, who had a patient with MPS 4A and saw the value of adding that disease. So that is another way that diseases can get added onto panels as well. So now that we have an idea of the current state of newborn screening, I want to talk a little bit about the crossroads that we are finding ourselves at in the newborn screening system. And largely it comes down to kind of 3 main components. One is this idea of expansion of newborn screening panels. There are more and more diseases that have more and more assays being developed, that have more and more treatments that may make them appropriate for screening. The second is this idea of using genomics in the newborn period. And then the third is how we can be more equitable in our access, not only to the screening itself, but to the downstream diagnosis and management. And so my goal today is really to kind of provide a look at where newborn screening programs find themselves and help us think about how we can advocate for these challenges and mitigating these challenges. So as I mentioned, we are seeing a huge call for the expansion of screening panels. We have more diseases in the queue than we have ever seen before at the national level and at the state level as well. And really this is a result of a confluence of 2 things: technological advancements, largely driven by work by Dr. Gelb or the potential for genomics with therapeutic advancements. So more and more diseases having effective treatments. And so we're seeing that come together. Unfortunately, at the same time, as we are faced with a pretty robust resource crisis in public health and medical genetics. And so this is forcing us to think about how can we keep pace with the need to screen for more of these diseases and help more and more children with the idea that we really don't have a lot of capacity. And this is gonna force us to think about implementation of screening differently. Do we still do it at a state by state level? Do we start doing regional screening? You know, how do we kind of bridge this gap that we're seeing grow? And I always, when I talk about expansion, also want to talk about the idea that we can't just focus on more, adding more and more diseases. We have to think about how well we're doing our screening. And this is the best I could come up with in terms of an example. And I know it looks a little bit odd, but if we think about a garden, and if we just take a garden, we just throw all the seeds at it, quantity, we want all the flowers, but we take no time to go back and actually take care of that garden, we will never reach the full potential of screening, never reach the full potential of our garden. We will inundate the system with false positives. We may miss children. This is not the only way we can do things. But if we go a little bit slower and we add diseases thoughtfully and we take the time to go back and water and check the pH and make sure that it is working as it should, then we can ensure that all of the goals of newborn screening are being met. So I implore you, as you think about adding diseases, not just to focus on just adding them, but to make sure that the programs are adding them well and using the best assays, the best tiered testing, the best methods available. So the second point that I wanted to bring up is this idea of newborn genomics, sequencing in newborns. And I think we've heard a lot about this. First, it's really important for us to understand what the heck we mean when we say that, because I'm pretty sure we all mean different things. And so I put together this slide to show that this can really mean a spectrum. So on the far left is really the application of it in a diagnostic capacity. This is really, I think, well accepted. We have a baby in a NICU, in a PICU, they have a phenotype, they have symptoms, we're trying to figure out what's going on. That's a diagnostic application. But what we're hearing more and more about is this application of screening, actually applying a whole genome sequence to newborns who appear to be healthy. And so there's a number of ways that this can be done, most of which right now in terms of a research setting is using this targeted whole genome sequencing option in the middle, which is really just looking at kind of a set of known genes associated with childhood onset diseases. But I want to caution us to not put all of our advocacy eggs in the basket of genomics, because while there is a lot of promise, it isn't the silver bullet for everything in rare disease. And there are a number of reasons why. In the newborn period, we have to think about timeliness. There are some diseases where we will not be fast enough using genomics. There are some diseases where we're barely fast enough now using biochemical and newborn screening. And so we have to think not just about what we're able to produce, but how fast we're able to produce it. We have diseases that aren't typically genetic in nature as we think about them. In fact, our most common disease that we pick up on newborn screening panels is congenital hypothyroidism, which by and large does not have an underlying genetic etiology. So genomics would not help us with these kids. And really our current understanding is still in process of genomics and what we understand. We know that quite a few genetic tests will pick up what we call variants of uncertain significance, which means we can't really tell whether or not it will cause disease or whether it's just going to be a benign change in your DNA. And we've seen this with a few of our diseases. We also have some diseases like X-linked adrenoleukodystrophy, where knowing the DNA cause, knowing the variant actually really provides us very little information on onset and clinical symptoms, even within the same family. And so as we think about this idea of using genomics and think about this possibility of having a lot more variants of uncertain significance, it's just something that we really, I think, have to be keen and aware of, especially because what we know of our genome right now in the United States is largely based on Northern European individuals, which means we see a lot more variants of uncertain significance in non-white individuals. And we have to think about that from an equity perspective. So one of the things that we are looking at doing, this is a project coming out of some work at CDC to address some of these information gaps around data, around variants, even around the biochemical piece, is we are building a national newborn screening data platform known as EDEN. And the idea behind this is that we would ingest and aggregate all of the newborn screening data from across the country, biochemical, molecular, and clinical, to allow us to do better in newborn screening using data, allow us to contribute to a better understanding of the rare disease community of these diseases that we're screening for. So we're really, really excited for this. We're maybe 3 years into development, probably 3 or 4 more years to go, but it's a great project and we're really looking forward to rolling it out. We also, in newborn screening, need to start kind of stop resting on our laurels, I'll say. Often we think that the universality of newborn screening, this idea that everyone has the opportunity to have newborn screening, means it is equitable. And that is not true. Because while we can screen for a baby and while we can test them, once we have that result out, we are essentially still putting them into what is decidedly a broken healthcare system. And so this is a quote from one of my favorite papers from back in 2015 that really appropriately pointed out that discovering a condition in the newborn period is not sufficient to eliminate disparities in outcomes. And as we continue to evolve, we have to make sure that we're taking this into account and that we're setting up the downstream infrastructures so that any baby, no matter their ancestral group, their geographical location, their socioeconomic status, reaches the same outcomes as anyone else. We've actually been looking at some data of some of our national data that shows, unfortunately, that newborn screening in itself does not necessarily lead to the same types of outcomes. So this is looking at an example of cystic fibrosis, which is historically thought of as a more white disease. And it's looking at time to diagnosis and time to treatment and intervention, comparing reported race against each other. The takeaway is in the red box, which is all things being equal, we still see all things being equal in terms of time to screen, time to reporting, that Black African-American babies and Asian babies have longer times to diagnosis and treatment than white babies, even with newborn screening. And so this is really a call to action for advocacy and thinking about that downstream piece to make sure that we do have some of those federal policies that Matthew mentioned in place to help families navigate the system. And ultimately, as we think about adding diseases and building the infrastructure, we in public health have quite a balance to think about. And I know there was a question about political transitions, and this is something we're certainly thinking about, especially as the feds gear up for a potential federal shutdown. It's always a balance of the resources available and wanting to do right by everyone. And so the more that we can have advocates at the table asking for the resources that we need, the better off we will be as a community. And so I'll end just with some ideas around what it really can mean to be an advocate in this space and some tips that I've seen personally work really, really well for those advocating in the newborn screening sphere. The first is to ask questions. Programs often want to help and they want to add, but they are constrained. And so try to figure out what the barriers are. Define your shared goals for moving forward. Do not be afraid to use your voice. Be patient. The government moves very slowly, very, very slowly. But just remember that glaciers move slowly, but they can make a big impact. So be patient. Collaborate, collaborate, collaborate. Teach. You have a lot to teach individuals who are making policy, who are setting policy, who are trying to implement. but also be willing to learn. And leave any egos at the door is always a great idea. And so I'll end before passing on to my other speakers to just indicate that this is such a great area. Newborn screening is such this beautiful mix of where people, policy, and programs can come together. And we really invite you to be part of this program with your advocacy. So thank you.